When patients present with a devastating brain injury that could result in neurological death, predicting the outcome can be very difficult soon after the admission of the patient to hospital. At admission, assessment of the extent of neurological damage can be confounded by cardiovascular instability, hypothermia, residual effects of sometimes unwitnessed seizures, the effects of alcohol or drugs, or a range of respiratory, metabolic, and acid-base abnormalities. A period of time spent stabilizing the patient may allow improvements in conscious level and neurological state. Such stabilization, therefore, facilitates informed prognostication and allows more rational clinical decision-making regarding the continuance or escalation of aggressive management on one hand, or the withdrawal of life-sustaining treatments on the other. This ensures that we don't prematurely give up on potentially retrievable patients. While the above discussion addresses patients at the time of presentation, similar principles apply to patients already being cared for on the ICU who show signs of sudden neurological deterioration. A logical consequence is that safe prognostication often necessitates admission of such patients to the ICU for stabilization and observation, or the continuance of active intensive care with similar aims when patients are in the ICU at the time of deterioration. During this period, some patients will continue to deteriorate, and it will become clear that continued active treatment is not appropriate. Some of these patients will clearly not meet criteria for neurological death, and following discussions with the family, withdrawal of life-sustaining therapy will be an ethical and appropriate course. However, the clinical picture in other patients will suggest that a diagnosis of death using neurological criteria is likely to be satisfied. In such settings, it's generally good practice to maintain cardiorespiratory stability to allow enough time for such a diagnosis to be established. In the majority of patients in this last category, irrespective of whether the patient has any potential to become an organ donor, testing for neurological death may be preferable to withdrawal of life-sustaining treatment without formal testing for several reasons. First, the diagnosis of death is confirmed, and any possible doubt that the patient had the potential to survive is eliminated, bringing clarity and closure for families. Second, the finality of the diagnosis avoids continuing futile treatment, which can prolong the family's distress, demoralize staff, and waste limited resources. Third, this process protects clinicians. The diagnosis of death using neurological criteria, when undertaken in accordance with national guidance, is accepted by courts in the UK, while decisions to withdraw life-sustaining treatment on the grounds of futility can be more subjective and potentially challenged in court. Fourth, this approach may provide more options for the family regarding organ donation. Finally, undertaking the test whenever the diagnosis is a possibility underlines the point that testing for neurological death is not simply a part of organ donation, allows clinical teams to become more expert at confirming death using neurological criteria, improves consistency in testing, and finally, undertaking the test increases learning opportunities for intensive care medicine trainees. At present, the tests to diagnose death using neurological criteria are undertaken on approximately 1,400 patients each year in the United Kingdom. This limits the experience individual consultants can get in making the diagnosis, particularly if they work in hospitals outside neurosciences centers, where the diagnosis is made less frequently. The purpose of this educational tool is to increase professional confidence in diagnosing death using neurological criteria and to promote consistency in making the diagnosis by following the recommendations of the Academy of Medical Royal Colleges. Like the Academy of Medical Royal Colleges, this guide will not be using the term brainstem death, as this can cause confusion, and to emphasize that the diagnosis is not anatomically based, but instead based on loss of function.